Good morning, good afternoon, good evening, everyone, depending on where you are in the world. I'm here with my good colleague and friend, co-moderator of this conference, Catherine Orrell, and we'd like to welcome you back to the second day of the IAPAC Adherence Conference 2020. We had a very rich and full day yesterday. I think only a few minor technical hiccups, so we're doing well, and thank you all for being in attendance. We also want to acknowledge to all of you, we know these are very challenging and trying times for so many of us, and we also want to express gratitude to all of you out there on the front lines for all the work you've done over the years and ongoing for the HIV pandemic and our goals to still end the HIV pandemic globally. And we know that many of you are also involved in and affected by the COVID pandemic and doing your work there as well. So we thank you for all your dedication and all of your hard work. And we also express our condolences to people we've lost to both HIV and to COVID disease. Thank you all for being here, and our best wishes for everyone to stay well and healthy. And thank you for joining us today for what we expect to be another rich and full day. And Catherine, let me turn it over to you.
Thanks, Bob, and good morning, good afternoon, everybody, again. I just have a few housekeeping reminders before we welcome our first speaker for the day. There are a number of pre-recorded sessions you can find on the amazing portal that we've been given for this presentation. There are also a lot of posters. People put a lot of effort into their posters, and I know this is a strange forum and we don't have dedicated time to go to these posters, but if you go to the poster hall, you can see them all there in PDF. You can copy to your swag bag and take them home with you if you would like as well. And there are also exhibit booths that are worth visiting in the exhibit hall. So please, during the day or after the day, or whenever you can, please go and have a look at those things. And also just to let you know that all the talks will be up on the IAPAC website by next week, so you can access everything retrospectively as well. Okay, so now I would like to introduce Dr. Int'l Bärnighausen. He is going to be presenting our Gary S. Reiter and Andrew Kaplan Memorial Lecture. Both of these two great doctors were caring and compassionate clinicians. Gary Reiter opened the first HIV/AIDS clinic in Western Massachusetts in an underprivileged semi-urban and rural population. And Andrew Kaplan was a clinician, teacher, and virologist who was the first to describe protease inhibitor mutations. Both were amazing clinicians, and in their footsteps, we always invite another amazing clinician to come and actually give a lecture in their honor. And Prof. Bärnighausen is also a medical doctor and a clinical specialist in family medicine. He's worked as a family doctor in Germany, China, and South Africa, and is currently the director of the Heidelberg Institute of Global Health, one of the research centers in the medical faculty and university hospital at the University of Heidelberg, which is Germany's oldest university, 1386. That's far older than anything in the US or South Africa. He's also the Alexander von Humboldt Professor at the University of Heidelberg, and senior faculty at one of the 5 global programs of the British Wellcome Trust, the Africa Health Research Institute in South Africa. Now, his research focuses on identifying, designing, and testing novel interventions for population health and establishing the causal impact of these interventions on population health. In particular, he works on large-scale population-based experiments in a number of areas of global disease burden, such as HIV, COVID-19, diabetes, hypertension, and depression. And I'm really looking forward, Till, thank you very much for coming, and I'm really looking forward to your talk today.
Thank you so much, Catherine, and congratulations to you and Robert and all of the organizers for managing such an outstanding conference. I learned a lot yesterday, and it's exciting as always and terrific that we managed to meet in virtual spaces when we're missing the physical interaction and physical spaces. It's an impossible two sets of shoes to fill, Gary S. Reiter and Andrew Kaplan, and a great honor to be able to contribute a little bit, continuing their legacy, and I'm honored and thrilled. The motivation for my talk is one you're very familiar with. We've seen, of course, the terrific successes of HIV programs worldwide in boosting aging and life and giving life expectancy back to people living with HIV. Here's an early result where we showed how substantial the life expectancy gains can be in one important place in the HIV epidemic in rural KwaZulu-Natal, South Africa, where HIV treatment likely boosted life expectancy by 1 year per calendar year. That's one of the fastest life expectancy increases the world has seen and in the history of public health. And of course, the hopeful victory over COVID-19 will give us similar pictures in the future. And with aging, of course, and as people living with HIV age, as anyone with and without HIV, but also, of course, because of HIV and because of treatment, we expect increasingly mortality amongst populations, communities living with HIV to be of non-HIV causes. And of course, that's a massive success of HIV treatment at scale. And this leads to the question and the title that the organizers have given me, long-term holistic care for HIV. How can that look? Are there delivery model innovations that we should look into? And I have examples here and want to stimulate the discussion a bit in 3 streams: desirability and integration, HIV effects, integration, other services, on those other services when they're integrated with HIV programs. On the desirability side, of course, HIV treatment still means in most places a walk or a drive to a clinic, and it's a primary care clinic. And in many places, for instance, in rural sub-Saharan Africa, in Eswatini, in Namibia, in Zambia, these can be long ways to overcome. And it would be very convenient if HIV treatment could, at least to some extent, be delivered to people's homes. And here is a study that has attempted to do that in Dar es Salaam, Tanzania, where we randomized the entire city and tested in a non-inferiority trial community delivery, community health workers, so-called home-based carers. They are an existing cadre in Tanzania, available to similar population ratios as physicians are in high-income countries. So community health workers are available, home-based carers are a government cadre, and we randomize all of the 48 primary care clinics in which ART is delivered in Dar es Salaam into community delivery, a community health worker coming to a patient's doorstep and providing ART, counseling, retention counseling, side effect screening, and so forth, and standard of care in the control arm, clinic-based, nurse-led HIV treatment. And we find in this non-inferiority trial that community health workers can indeed do it as well as nurses, under, of course, the condition of a well-integrated program. And community health workers here go back to their primary care clinics to which they're linked for continued mentoring, for discussion of particular cases, and also have a effective and sustainable referral chain upward to primary care clinics. The desirability side here in this one example of a novel delivery model for ART was also quite surprisingly good, to me at least. Patient satisfaction was very high. We were afraid that potentially patients saw a community health worker as a second best option and much preferred the nurse in the clinic. Clearly here patients also had choice and could opt to go into the clinics. They were simply offered home-based care, and the satisfaction across a wide range, I just showed 2 here, satisfaction metrics was extremely high. Patients appreciated the fact that it became more convenient, more pleasant, more desirable to be in long-term care. And of course, there is a cost savings, not to be underestimated on the patient side. On the other hand, and just a small warning in the discussions now on long-term healthcare financing for HIV, clearly we need substantial financial support, substantial resources support over decades to come. And COVID-19 and the UHC agendas are there in our policy field as well, and we need to find ways to make it all work together and fundable. The instinct here to go to user fees is, of course, the precisely wrong instinct, and we show that here in this study, where we ask people for the willingness to pay for this convenient, desirable service. People are engaged, they're satisfied, but we would lose the majority of clients if we charge them at $1 per month. So the idea to charge people for a service, clearly it has been a bad idea. It exists, user fees, and they are always regressive. Also, what we find again here, those with higher SES are much more likely to drop out of HIV treatment, community delivery, home-based delivery at $1 per month. So we would again have a regressive financing approach and lose clients who could benefit in their long-term care from a novel treatment delivery approach. And we're currently testing in Eswatini community health workers in a context of extremely high HIV prevalence. As you know, the Kingdom of Eswatini has one of the highest HIV prevalences in this world, partially because of a highly successful treatment program. And we are testing in this context community health worker led and supported delivery for hypertension screening, long-term care, diabetes screening, long-term care, with a grant from the world's largest program for science, the European Union's Horizon 2020, and the Global Alliance for Chronic Diseases. And thinking about how this could work and how potentially there are novel forms of long-term care for HIV treatment patients who now increasingly will live in a good situation of near normal life expectancy, and with hypertension and diabetes and depression and other chronic care needs, integration clearly on the agenda of HIV treatment delivery. Model innovations is one important slice and one key way to think about model innovations. And here we have reviewed systematically the evidence base on studies of effects worldwide. We found 102 studies, most in sub-Saharan Africa, which is terrific. These little dots that you see, they represent population sizes in these studies. They're of different size. The different colors mean different programs. And I dive a little bit into the details of these studies to share these findings and stimulate a discussion and thinking about integration. Clearly, it is something that carries risk, and clearly it is something that we need to engage with, both for long-term sustainability in the era of UHC and also for convenience, desirability, and patient outcomes in the long run. And I'll approach it from two sides. One is the integration effects on the HIV care cascades, and the other side is the integration effects on non-HIV functions within the health system. You're all familiar with the care cascade in HIV, and we in 2017, I think, published the first truly longitudinal population-based cascade, starting in a population in rural KwaZulu-Natal and then seeing people progress and seeing the successes and failures of the HIV care cascade. So, of course, we can be interested in what integration could mean in terms of cascade effects. And I'll walk through the three places where we start as clinicians, which is mostly facility-based, maybe in the future also partially community and home-based. But here is the first effect, the effect on retention. And we look here in these 102 studies we identified in our systematic review and meta-analyses. We look at the effects of integrating tuberculosis treatment into HIV treatment programs, family planning, maternal and child health, primary care, substance use therapy. And we see that overwhelmingly it boosts retention in programs. And very similar for adherence. Far fewer studies have actually looked at the adherence effects of integration, but overwhelmingly, again, most studies find positive effects, probably because care becomes more convenient. It's easier to go to a one-stop shop than to many stops in a health system's journey. So the client's journey here becomes more convenient, easier. It's very plausible that retention and adherence improve. And in as far as we know, again, in a range of studies integrating HIV treatment with maternal and child health care, sexual and reproductive health, viral hepatitis, substance use, mental health care, again, we tend to see positive effects on viral suppression. And the other direction, of course, is as important. The hypertension care cascades look far worse worldwide than the HIV treatment cascades. I think we rarely realize how far worse in low and middle income countries other chronic care cascades tend to be. And here we showed, Pascal Geldsetzer, one of my former doctoral students and postdocs, showed here in a large study where we combined 44 nationally representative population surveys in low and middle income countries, including the WHO STEP surveys and similar enterprises, where we have information, biomarkers, and self-report on the treatment and care cascades for hypertension. And you see here in 4 world regions, including sub-Saharan Africa, on the lower bottom corner, the dramatic losses along those cascades. Rarely across world regions is hypertension well controlled. That's a fact, and of course, a major loss in terms of health and life expectancy. And very similar also, another PhD student and former postdoc of mine, Chen Mangola, showed here in Lancet Diabetes and Endocrinology that the diabetes care cascades in sub-Saharan Africa are dismal and far worse performing than HIV treatment and care cascades. So there is an interest, of course. Does integration make care worse or better, make cascades better or worse performing? And again, hopeful. So I show here the summary outcome on the treatment successes when a HIV treatment program is integrated with another health systems function: tuberculosis, maternal and child health care, primary health care, non-communicable diseases, mostly hypertension and diabetes, viral hepatitis, substance use therapy, and mental health. And again, the effects are overwhelmingly positive now from the point of view of the other health systems function, depression treatment, long-term treatment for viral hepatitis. Overwhelmingly, there is a boost to treatment success if we integrate for those patients who are also receiving HIV treatment. So in summary, the delivery model research agenda and innovation agenda, I think, can powerfully boost patient satisfaction and efficiency, convenience and desirability, and make programs more sustainable. Integration, as far as we know, overwhelmingly improves HIV care cascades. It tends to strengthen other health system functions. And I do think we can substantially strengthen the evidence base. It's almost a trivial statement in science, but we do know a lot and we know enough to act. But while we're acting to learn, it's an agenda that is critical for the long-term sustainability of ART programs. It's critical for increasingly multi-morbid aging HIV populations who can benefit from more integrated and more holistic approaches. And this is the modern era of multiple offices in one room. I'm, on the other hand, in a call with the Global Health Hub Germany, the country where I'm currently sitting, where I'm the co-chair of a Ministry of Health network and advisory body, and the German Ministry of Health has just published its global health strategy. And I just wanted to advertise that Germany wants to very clearly signal that it's a partner, a global partner, a multilateral partner in supranational bodies such as WHO, but also with many countries worldwide, and is clearly very keen to support in humanitarian ways and social ways and many fundamental ways, research and innovation, but also delivery agendas. And has a strategy now with 5 points, one of which is health system strengthening, I think, into which this type of research and this type of action fits well. And Germany, I think I'm allowed to speak in that way, is keen to be a partner to all of you. And I would love to hear from many of you. My email address is on the left-hand, on the lower right-hand corner in this slide. Thank you.
Thank you, Till. That was amazing. It speaks very much to my heart in terms of scaling things up in sub-Saharan Africa. The need for integration and the need for differentiated service delivery models to make life easier for patients on every day, to offer them some choice, some space to be a human being in our public health systems is really, really important. So I thank you very much for that. We have a few minutes, and so we'll be closing the session to get everybody online for the next one, and we'll be right back shortly. Thank you again. Till amazing talk.